Thank you. Thank you. Good afternoon. Hello to everyone here in person and to our global live stream audience. Welcome. We're so happy to be hosting this and to bring this really important information to everyone. I'm Dr. Karen Adams. I am a clinical professor of obstetrics and gynecology here at Stanford and the director of the Stanford program in menopause and healthy aging. And I am thrilled to be with you today to have this really important conversation about our brain health. So I'm just going to ask you, if you feel comfortable, to raise your hand if you have a loved one, a female member of your family or a friend who is dealing with the effects of dementia. A lot of us. Raise your hand if you know more than one person, if you have two or more family members. Yeah, me too. Yeah, me too. I'm one of three sisters, and my older sister was diagnosed with early onset dementia at about age 52. And she had a slow, long decline for almost 12 years. And she passed away at age 65 because she forgot how to swallow, and she died of pneumonia. My mother was living independently until age 87 when she had to go into memory care, and now she is having to be fed because she can't remember how to feed herself. So I would imagine that this terrible disease has affected everyone in this room to one extent or another. And so it's very, very, very critical that we come together in events like this and we talk about the burden that we share, the impact of this disease on all of us, and what we can do to really protect our brains as we move through our lives. And I want to just acknowledge that this conversation might be challenging, a little bit hard to hear for some of you. And if that's the case, please take care of yourself, drink some water, go outside, get some fresh air. Just do what you need to do to take care of yourself. But I'm so glad you're here. I'm so glad we're having this conversation. And I am absolutely beyond thrilled to introduce you to our speaker. We are so fortunate to have Dr. Sharon Sha with us at Stanford. And we have all the questions, and she has all the answers. Right? No pressure, no pressure. And if she doesn't have the answers, she's working on getting them, which is what is so incredibly valuable and important about the work that she's doing. So Dr. Sha is a clinical professor of neurology here at Stanford, and she is the brilliant mind behind the Memory Disorders Division and the Stanford Memory Disorders Center. She also leads the Huntington's Disease Center of Excellence and the Ataxia Clinic, and she is a driving force behind some of the most cutting-edge research that we're doing here at the Stanford Alzheimer's Disease Research Center. Her mission is finding treatments for Alzheimer's and other neurodegenerative disorders, and she is making a real and important impact. She has served on the California Governor's Alzheimer's Prevention and Preparedness Task Force, and she's been featured in international media like the BBC's How to Stay Young and the docuseries Limitless with Chris Hemsworth. Today, Dr. Sha will walk us through everything that we can do about our brain health, from risk factors, what we can do today, to the groundbreaking research that she's shaping the future of dementia care and prevention. And remember, as she's speaking, you can put questions in with your QR code. And Dr. Sha, it's a pleasure to welcome you to She Talks.
Hello, everyone. Thank you so much for taking the time. Thank you, Dr. Adams, for that wonderful introduction, and to Carla and her team for organizing here today. Truly, I know all of you here, almost 400 of you and 2,500 live streaming today, have taken time out of your busy schedule to think about your brain, take care of it, But did you know that by being here today, you are reducing your risk of developing dementia? Just doing that, fantastic, applaud yourselves. So in the next hour, I'm going to tell you why just being here will reduce your risk. So one of that is socializing. Sorry to those at home, but I hear that there's a watch party or multiple, so that socializing helps. I'll give you some evidence behind that. We're going to talk about how keeping your brain active, cognitive stimulation, helps reduce your risk. We'll talk about how the wonderful food that we have here, the salmon, the vegetarian options, Mediterranean heart-healthy diet helps reduce your risk. I hope you're not sleeping during the next hour, but that contributes to a good, healthy brain. And if you haven't had a chance to exercise yet today, it's a beautiful day. Hopefully after this, you'll get some time to exercise. If only we could be doing some exercises while I'm chatting, but unfortunately that's not part of it. You know, we'll be talking a lot about reducing your risk, but I want to give you a little bit of an overview of what we'll go through. A lot of questions that I get from patients and families are, what happens as we get older? What is normal aging? But what's the difference between that and dementia? And what's the difference between that and Alzheimer's disease? What are the main risk factors that are present for dementia? And how do we reduce that risk? So we'll go through that as a tour de force, hopefully. Now let's get into it. I really love this artwork by Jan Langer. He took photos of centenarians and compared them to their younger selves. And I looked at this and go, not only do I think about what changes externally, but what happens internally to our brain as we get older. There are some things that we know stay the same. So here's the good news, right? As we get older, our acquired knowledge, what we know, what we're learning today, stays with us. Our vocabulary tends to stay the same, maybe a slight decline after age 80. And I would like to argue that wisdom increases. If we think about the decisions, I think about the decisions I made when I was in my mid-20s are not the decisions that I would make now at almost 49. So those are things that are preserved as we get older. What's normal aging? So the bad news is that the peak of some of our cognitive functions, like processing speed, is in our mid-20s. So there's a slight decline. But again, let's remind ourselves that maybe the wisdom is not the same as in our mid-20s. There are some things that also decline slightly. The efficiency of learning new material may decline slightly as well. Working memory. So what do I mean by working memory? Well, for those of us in the room who remember rotary telephones, and if you were saying, oh, well, I'm going to make that call, but I'm not going to write it down because I don't have a piece of paper, I'll remember those 7 digits. So working memory on average is about 7 digits, or those 7 pieces of information. As we get older, though, maybe it decreases to 6 digits. So it doesn't go away completely, but there's a slight decline as we get older. Our novel learning as well, so how much we can learn at a time, and then our brain volume. So what do I mean by that? Unfortunately, like other parts of our body that shrinks as we get older, our brain shrinks too. In general, there's atrophy or that shrinkage all over the brain, and on average, it's about potentially 5% per decade, or 0.5% or percent per year. But if we think about certain diseases, like Alzheimer's, for example, there are certain areas of the brain that are particularly affected and can atrophy at a faster rate. So if you look at the top, on the left panel, is a coronal picture of an MRI. So we're looking face on. And you compare that to the bottom panel on the left, where there's shrinkage or atrophy of the hippocampus. And the hippocampus means, in Greek, seahorse. You have a little tail. And what you see the difference is that there's atrophy in that hippocampus. And that makes sense for people who have Alzheimer's disease, where there's difficulty in making new memories. That part of the brain isn't working as well. And on the right panel is an axial view of the MRI, so it's cut through here, through my ears and eyes. And you can see that same area of atrophy in the bottom slide versus the top. So Dr. Adams sort of stole my thunder here, but I will ask you to raise your hand again, because I want you to think about some of the demographics here. Raise your hand if you know someone with dementia. And so that's almost everybody here. Now keep your hand up, keep it up, I know. Keep it up if this person is older than 65. Put it down if it's less than 65. Not that many people put their hands down. Keep it up if this person is a woman. Put it down if it's a man. So maybe a quarter, you can put your hands down now. Maybe a quarter are women older than 65. So we'll get into some of these demographics and the different types of dementia. So one thing that people ask me is, what is dementia? How do we define that? What does that mean? So dementia means that we have a problem with thinking that makes it hard for you to take care of yourself. And that thinking, the cognitive processes, are typically could be in memory, could be language, could be executive function, could be visuospatial function. And that's severe enough to make it difficult for you to take care of yourself, whether it's shopping, cooking, finances, laundry, working, driving, things like that. But we don't wake up suddenly with dementia. There's a precursor called mild cognitive impairment. And that's what it sounds like. There's a cognitive change, a cognitive impairment, that is at least a standard deviation below age-matched norms. Now remember, as we get older, things can change, so it should be age-matched norms. But it's mild enough that we can take care of ourselves. Maybe we have to modify slightly, maybe it takes a little bit longer, but it's mild, so we're independent in that functional taking care of us piece. And then there's the normal aging piece. So you can imagine there's like a slow process that can progress from mild cognitive impairment to dementia. And there are different kinds of dementia. That's the difficulty that some people have not yet learned, that Alzheimer's disease and dementia are different because Alzheimer's disease is a type of dementia. That Alzheimer's disease is the most common type of dementia, and that's why we tend to equate the two. The top three there under that arc are the most common types of dementia. Lewy body dementia is the second most common dementia that you've never heard of, essentially. Parkinson's disease dementia and dementia with Lewy bodies are all encompassed in the term Lewy body dementia. I want to take a moment just to tell you what that is because it's just so common. Robin Williams made it famous because he had hallucinations, and that's one of the things that we see in this disease. Not everybody has that. Visual hallucinations. People can have Parkinson's symptoms like tremor, stiffness, slowness. People can act out their dreams. There's a sleep disorder part of this. And people can have cognitive fluctuations where they're really sharp and alert, and sometimes more sleepy, confused, and it waxes and wanes like a delirium. The cognitive symptoms that typically occur are executive function, so multitasking, planning, attention, and visuospatial function. And this disease, unfortunately, about 50% or more can also have Alzheimer's disease. And when we think about Alzheimer's disease, at least 30% of them also have one of the Lewy body dementias. We don't yet understand why they co-occur and what makes someone's brain vulnerable to have both. Vascular dementia is a dementia in which people have had strokes in the brain and then causes cognitive problems. It can be a big stroke or it could be little strokes that build up over time that we're not aware of. Again, not mutually exclusive. And then the bottom category there are more rare diseases. Frontotemporal dementia tends to affect people who are younger than 65 and have behavioral difficulties such as disinhibition. Sometimes I have that. Compulsive behaviors, decreased empathy, carbohydrate craving. Again, sometimes I have that. And then Creutzfeldt-Jakob disease, very rare. It became famous more in the 1990s and early 2000s with mad cow disease. And then CTE, chronic traumatic encephalopathy, we hear a lot because of concussions, head trauma related to American football, soccer, boxing, things like that. We don't have time to talk about that bottom category very much today, but I will say that head trauma in general is a risk factor, and we'll get into that. So what about Alzheimer's disease? I saw all these hands raised. It affects over 50 million people worldwide, 6.9 million Americans. Often symptoms are the memory loss. You remember that photo we talked about, the hippocampal atrophy? We tend to see memory loss. And then this side view, the sagittal view of a PET scan here, this is a FDG, fluorodeoxyglucose PET scan. We give someone like a glucose tracer, and see how it is metabolized in their brain. And the red is where it's metabolized well. What you see in that back part, the parietal lobes, there's less metabolism there. And those parietal lobes help us with thinking of words, help us with navigation. So you can see those familiar symptoms that we see in Alzheimer's disease. What a lot of people don't know, and we've learned through the years, that the pathological changes of Alzheimer's disease begins 15 to 20 years before those symptoms begin. So in these beautiful stock photo people here, people who are my age, the symptoms may begin now. And that's why it's so important that you're here learning how to take care of your brain, because if there are things we can do, we should do them not only now, but throughout our entire life. So what are those pathological changes? Well, in that lower left panel is the amyloid beta plaques. So the amyloid protein is something we talk a lot about. And on the right lower panel is these tau tangles. The tau protein builds up. And the two of them are present to get that definition of Alzheimer's disease pathologically. The two of them sort of build up, muck up the works, and cause the neurodegeneration or the neuronal loss and atrophy that we see. And I promise I don't have too many graphs, but I do like to show you the science behind what we've been learning. So on this x-axis, on that bottom row here, is time. And then on that y-axis, that vertical row, are the biological changes, what we call biomarker changes in the brain. And in the first red that starts to rise is when the amyloid starts to build up in the brain. And then next we see in that blue line is when the tau starts to deposit in the brain. And as time goes by, in that pale green is when we start to see structural changes, like the atrophy on the MRI that I showed you, or the hypometabolism on that FDG PET that I showed you. And then in the purple is when we start to see memory loss. And then finally, in that dark green, further time has gone by, is when we have that functional decline that we see in dementia. So from the onset of that red with the amyloid in the brain to that dark green can be 15 to 20 years. And that's why we see a lot of interventions and clinical trials trying to target those proteins as early as possible, hopefully to prevent further disease. And you all know that there are no cures for Alzheimer's disease right now. What I'll tell you is that there have been some developments in the past couple of years. What we have typically is that over time, again on that x-axis, if memory is on that y-axis, people get worse with Alzheimer's disease. The symptomatic medications that we've had before are really delaying that decline. The slope is the same, but we're trying to delay that progression as much as possible. And what we've been looking for in research and clinical trials is really something that's disease modifying, slowing that slope, attenuating that slope. And what's been really exciting in these past couple of years is that we have drugs now that potentially can do this. And so this is a graph from donanemab. It's a monoclonal antibody targeting amyloid. So you saw amyloid was the first thing that deposits in the brain. Can we get rid of it? If we get rid of it, does that slow all the downstream effects? What we're seeing here is that over time, the people in the clinical trial that got placebo, the fake drug in this dark blue, get worse as measured by a functional scale. And then in the orange, the people who got this monoclonal antibody, this graph is of donanemab, got less worse over time. This trial was done over 76 weeks, so we don't know yet if it continues to separate over time. So we have continued attenuation of that progression of that slope, but we're very hopeful. Lecanemab and donanemab were approved, lecanemab in 2023, donanemab in July of 2024. We're very excited that these drugs have come to market, FDA approved, but it's not without side effects. All new drugs do. These ones cause cerebral edema and cerebral hemorrhage. What does that mean? Brain swelling and brain bleeding. Oh gosh, yeah. And depending on the drug, it can be 20 to 35% of the patients who get this. So it's not without risk. And it's their infusions, given every 2 or 4 weeks. So it's a little bit like undertaking chemotherapy. So really got to understand the risks and benefit here. So you can imagine we're excited that there are new drugs, but we need more, right? We need more that's easier to get that are more safe. If we talk a little bit about what's been changing in science in these past 20 years, we've seen reductions in amazing research with breast cancer, prostate cancer, heart disease, stroke, HIV, but Alzheimer's. 5th leading cause of death. It's rising. And it's more common in women, right? We saw those hands, right? Majority of us know someone who's a woman that has dementia. And I would venture to say that it would probably be Alzheimer's, just given the prevalence here. Not only are 2/3 of people with Alzheimer's women, but women are more likely to be unpaid caregivers. Women tend to be the ones that are the ones that give 24-hour care or have to give up their jobs to take care of their loved one, or have to quit work. Whereas the lifetime risk of breast cancer is 1 in 6, or 1 in 11. The lifetime risk of Alzheimer's disease is 1 in 6. And the things we know about race and ethnicity, we still don't fully understand. What you see from this graph is that people who are of African American descent, American, Indian, and Alaskan natives in that, I think it's purple and light blue, are more likely, whereas Asians are less likely, and Pacific Islanders, where Caucasians are right in the middle here. And what about genetics? We heard Dr. Adams mention family members. Oftentimes I get this question in my clinic about, well, my mother had it, my grandmother had it, I'm worried about my own risk. Well, the good news is that this, what we call autosomal dominant, where if you develop this gene or inherit this gene and you're 100% likely to get this disease, is very rare. It's less than 1% of people who have Alzheimer's disease. And the symptoms typically develop in those families at mid-40s, so very young. It's very rare, and we see these in certain areas of the world like Colombia, Jalisco, Mexico, and you see that in generations. So their mother had it at age 45, their grandmother had it at age 45, so very rare. What we tend to hear about in, say, the media and research is a risk gene called apolipoprotein E4. You may have heard about this. You can get this testing done commercially. We inherit one copy from mom and one copy from dad, and you can inherit one of 3 versions, ApoE2, ApoE3, or ApoE4, the risk one. Where ApoE1 went, I don't know. ApoE3 confers a neutral risk, no greater risk, no less risk. ApoE2 is rarer, and it tends to be protective. ApoE4 is the high-risk one. And what I used to tell people 10 years ago is that if you have one copy, you increase your risk about 4 times the normal population. And if you have 2 copies, it increases the risk about 10 times the population. And why am I telling you stuff that I used to talk about 10 years ago? It's because we've learned since then, actually, there's some things that change that risk and those numbers that I quote. So that's sort of the general studies, but a lot of those studies were done on white European ancestry. So when we look at, say, African ancestry, people who are of African ancestry tend to have ApoE4 more prevalent, meaning there are more people who have ApoE4. But if they have one copy, the risk is not very much higher. And if they have 2 copies, it's maybe 4 times the risk. Compare that to the 10 times the risk that I just quoted you with 2 copies. And if you're of East Asian ancestry like myself, it's very rare to have an ApoE4 allele at all. If you have one copy, it's about 10 times the risk. And then if you have 2 copies, it's over 25 times the risk. And if we talk about Latino and Hispanic, it's too much of a grab bag to be able to give you some confident information, because whether that's from South America, Mexico, Spain, it's very mixed. So basically saying that some of these numbers that we're quoting, we have to do more understanding to see what my individual risk is. And then, what about women? One of my colleagues here at Stanford looked at women who have ApoE4 and saw that they had a greater chance, so women who have ApoE4 have a greater chance of developing Alzheimer's disease than women who don't have ApoE4, but that same risk is not present in men. So could that be part of why we see it more in women? Probably, but there are other factors that we have yet to understand. So it's something to remind ourselves, though, that this ApoE4 is not present in everyone who has Alzheimer's disease, about 65%. So having that gene is a risk factor gene, but not one that confers 100%. And there are people who don't have Alzheimer's disease and have ApoE4, about 15% of us too. So just to know that getting that genetic testing does not determine your fate, all right? And we're gonna get into that a little bit later too. All right, what are the risk factors? Already alluded to some of them if you've been paying attention, right? So age is the biggest risk factor, actually. So maybe, say, 2% of people above the age of 65 to 70 have Alzheimer's disease, but above the age of 85, it's 30 to 50% of people. So age is that big risk factor, but not everybody gets Alzheimer's disease or dementia. We talked about the genetics and how that ApoE4 increases the risk. We talked briefly about how head trauma increases the risk. Vascular disease, high blood pressure, high cholesterol, diabetes, smoking, that increases the risk for Alzheimer's disease. Low education and poor sleep. And this last one is sort of peeking its head. People are doing more research about air pollution. So if you look at these risk factors, well, let's think about what we talk about as modifiable risk factors. So that's something you can do something about, right? Can't change our age as of yet. Can't change our genes. Love you, mom and dad. We can't change that. But there are certain things we can do. Reduce our risk for head trauma. Take care of some of the vascular disease, eating healthy, right? Taking care of our brains with cognitive stimulation, educating ourselves. Maybe we can get better sleep and live in a healthier area. So something that I love talking about is exercise. So that's why I say make sure you get outside in this beautiful day if you haven't done so yet. The reason why I like to talk about exercise is it helps reduce our risk in so many ways that we have yet to understand. And I like to quote this study. It was done in 2011, quite old in terms of research, in which the researchers took about 120 people and split them into two groups, older adults, maybe average age 67 or so, and one group did stretching, and the other group ran on a treadmill a few times a week. And I think you can guess what I'm about to say. The people that did stretching, they measured their hippocampal volume, so that memory center, and after a year, the volume shrunk as you might expect. That's the red in this graph. But the exercise group, not only did they not get worse, they gained the size in their hippocampus. And on memory tests, they did better. Now, if you don't like the treadmill and for you it's just something to hang clothes on, you don't have to do running on a treadmill. Research subsequent to this has demonstrated in all kinds of ways, whether it's nature walks, weight training, yoga, all of this stuff is so good for your brain, and we don't yet fully understand why. And I think this is one of the 500 questions, is what type of exercise should I do? Something is better than nothing. And we think not just the blood flow, the perfusion, but there are things that are secreted when we exercise, things like BDNF, brain-derived neurotrophic factor, maybe other things. Right now, we don't have something, an elixir you can drink. You actually have to do the work. So get out there. All right. What else? Nature. I always try to get outside. Why? I feel so good after. Why do I feel so good? I don't know, but there's some research that says some ideas about how it's good for your brain. So in this small study of university students, 60 participants, again, so they're university students, so younger, they were instructed to go for a walk downtown, half of them, and the other half walked in the park. Then they came back and did cognitive tests. And the nature people, they did better on executive function tests. So that's sort of like the attention, concentration. We always say that, right? When you're stressed out, take a break, go walk outside, right? There's something to be benefited, whether it's so much drawing on our working memory, or is it the stress release? Is there something that's being secreted in the environment? Good for us, right? So it really helped attention. So lifestyle. So this lovely food that you have, we always say, hey, what should I eat, doctor? Coconut oil? Is it curcumin? You know, what's been studied the most is the Mediterranean heart-healthy diet. But I say to people who are not of Mediterranean descent, I can't tell my dad, don't eat rice, you know. But I will say to my dad, let's ramp up the fruits and vegetables. Let's have lean, healthy proteins, because that's what's good for brain health. And what people don't want to hear me say, sorry guys, alcohol is not part of the equation. That's one of the 500 questions. Alcohol is a toxin. It might make you feel good, but it's not good for the brain, and your brain has to work in overdrive to function. And if you already have a brain disease, it's really going to hurt you harder. So I say you don't have to be completely dry, but save it for special occasions. I got to save my chocolate chip cookies that I crave for special occasions because we can't have this every day. So in this study that I want to tell you about, the researchers took almost 4,000 older adults, so people older than 65, and split them into two groups, those that had healthy lifestyle. So the exercise, the cognitive engagement, the socializing, the healthy diet, all of that. And then those who didn't, had more of a sedentary lifestyle, not really keeping their brain active. And then split them up into ApoE4 carriers and non-carriers. And so I'm going to focus your attention to the right graph first. And it's sort of what you might expect. So in the non-ApoE4 carriers, those who had the healthy factors in the dashed lines had a lower risk of developing dementia and had a better cognitive score. And those who did not have those healthy factors were worse off. And then the same thing was mimicked in the left graph. Those who are ApoE4 carriers with that higher risk gene, again, the healthy factors were better off than those who did not have those healthy factors. Now let's compare graphs with the dashed line on the ApoE4 carriers on the left with the solid line on the ApoE4 carriers on the right. And they almost look the same. And the reason why I mention this is that, even though we think our genes are our fate, what this, I think, research is showing us that even though you have that higher risk gene, but if you have that healthy lifestyle, that might negate your risk to someone who has not that high risk gene. So there's still a lot that we can do. I promise I'm almost done because I don't want you to fall asleep when I talk about sleep next, okay? So finally, so this study was done several years ago also, looking at sleep. And what the researchers did was had self-reports of sleep, those who slept less than 6 hours and more than 7 hours, okay? And I know, gosh, I didn't sleep enough last night either. What happens? Well, what they measured was the amyloid protein in the brain with this PET scan. And what you can see is the amyloid protein is depicted as red here. So in those in the right column, we see there's more red in people who sleep less than 6 hours. And those who sleep more than 7 hours have less red, so less amyloid buildup. So this was a study that was done a long time ago, but researchers since then have also showed that the amount of non-REM sleep, the quality of sleep, also has effects on tau protein buildup, potentially suggesting that when we're sleeping, not only is the quality and quantity of sleep important for reducing our risk, but even these bad proteins that are contributing to Alzheimer's disease and others. Now, one thing that I want to say that's really, really been rising in research in the past year to two is a way to diagnose. So we're talking about lifestyle, things that we can do, but we can actually start to diagnose things even earlier now. So with the amyloid and tau that we see in Alzheimer's disease, on the left panel, we can do PET scans to look for amyloid and tau. We can do spinal fluid tests. We can even do blood tests now. All of these have caveats, though, so if we get into it, I can tell you all the caveats. But there are ways to diagnose now that until we have a pure way of preventing, I would not recommend everyone go get all these tests done, but I think if we have concerns about our cognitive problems, there are better ways to diagnose now and then put ourselves on that sort of curve that I've showed you earlier. Now on this right panel, we have developments in the past couple years also about diagnosing Parkinson's and Lewy body disease. We can do that in spinal fluid and skin biopsies. So a lot of progression in ways that we can diagnose, potentially where I can see ourselves, where we all go to the doctor for our health maintenance and say, hey, what's my cardiovascular risk? Do I do some blood tests and EKG, do some cancer screening, and potentially do some neurodegenerative screening? And hopefully we'll continue to develop research that we can have drugs and medicines for not just lifestyle, but really for prevention and treating all of these dementias that we've talked about. So with that, I really appreciate all of your attention today, and I'm happy to take some questions.
Thank you. Why don't you have a seat, Dr. Sha? So hopeful. Oh my gosh. I really feel like there's some stuff we can do. Thank you. Thank you so much for being with us. And I have 500 questions.
How much time do you have?
Right. We'll be here till tomorrow. So the first one that we got a lot of questions about hormone therapy. So we used to call it hormone replacement therapy. We now call it hormone therapy. And the question is, does hormone therapy increase cognitive function? Or does it decrease the risk of cognitive decline? And is there a specific time you need to use it to be effective?
Yeah, I feel like this question is best targeted to you, Dr. Adams, so I'm going to do it justice, I hope, as much as possible. Feel free to add to this. So, I think there's been a lot of controversy in this hormone replacement or hormone therapy in the past couple of decades. I think the early research was suggesting that it was harmful, actually. And then some more recent research are wondering whether the timing of treatment could be more beneficial, potentially, within 5 years of menopause, though it's still controversial and there is no clear answer. And no clear answer to say that it prevents.
Right.
Tell me if I did it justice.
Perfect. Perfect. It's complicated, like everything. It's not a straightforward answer. We do know that initiating hormone therapy after age 65 really does increase the risk of dementia. It increases it. Isn't that crazy? We always think it's brain protective, but starting it early makes a difference versus starting it late. So after age 65, we generally say no. There are 4 randomized controlled trials looking at putting hormone therapy for women who are postmenopausal under age 65, and they showed no benefit. So we have 4 trials about that. The really unanswered question is, what about those people who are in perimenopause, having hot flushes, and really symptomatic? Because in those big 4 trials, none of those women were having symptoms. They'd already gone through their transition. But hot flashes are a culprit. And what we have found, I know, right? Is it hot in here or just me?
Yeah.
When you are hot flushing, you see an increase in the amyloid plaques in the bloodstream. And when they treat the hot flushes, whether it's with hormones or not, even a non-hormonal method, they see decreased white matter hyperintensities in the brain and decreased amounts of amyloid plaques in the bloodstream, or amyloid, whatever those markers are in the bloodstream.
Amyloid plaque, exactly.
Those things.
Right.
Yeah, so markers of brain function. And so we don't know if that means that treating somebody who's hot flushing will somehow impact dementia risk. We don't have that data and we don't promise that. But it's very interesting that when you treat hot flushes, there are some markers that change. So it may be when someone says, nobody ever died from hot flushes, I think I'm just going to wait it out. No, you probably should get it treated because it potentially could have an impact on your brain health later on. So that's a really good reason to treat. And then there's some really interesting data too about how hormone therapy or how people age impacts the estrogen markers in the brain. Lisa Mosconi's work. Do you?
I don't know her.
Oh, so she's at Cornell. And she is doing PET scans in the brain, funded by the National Institutes of Health and Maria Shriver. Maria Shriver's very interested in this. And what they have found is not looking at hormone therapy, but just how women's brains change as they age. They have more and more and more estrogen receptors lighting up in the brain as they age. which I think is fascinating, right? Because it's like the brain is trying to sop up all the estrogen that it can possibly get. So we are seeing changes in the brain with aging, and it's a really interesting area of research. And you and I should talk.
Yeah, I want to talk to you more, because
we should do some research.
I know we're supposed to go through these 500, but I do want to ask the difference, because hormone replacement therapy, or we call it hormone therapy, typically includes estrogen and progesterone.
Right.
But when I was reviewing the data in preparation for you guys, it seemed like estrogen specifically.
Yes.
Now,
right.
yeah. So is that consistent with what
I think that's a really good point. That's a great point, because estrogen is what's mostly been studied. Estrogen seems to be what is sort of modulating our symptoms and that sort of thing. And the progesterone is only to protect the uterus in people who have a uterus. And so really it seems like most of these symptoms are modulated by estrogen, and most of the studies have been just looking at that. That's a really good point. Question number 2. Yeah, we'll be here all day for sure.
Okay.
All day. Enjoy your lunch. We'll bring you more.
Yeah.
I am on an SSRI for my mental health and statins for my heart health. Are these drugs safe for my brain?
Yeah, fantastic question. So the SSRIs, that stand for selective serotonin reuptake inhibitors. And what I sort of alluded to but didn't say specifically is how feeling happy helps reduce our risks. You can imagine high stress, anxiety, all increases our risk. And we also see mood disorders associated with the various dementias. So treating any mood disorder may be very, very helpful for you. I don't know that just that drug specifically would say reduce our risk, but I think the environment of feeling happier reduces our risk. The thing about statins is that we know that statins are great for reducing risk of developing stroke. And there have been questions about statins specifically being bad for the brain or potentially causing problems with memory. In a large review of statins, because I was getting these questions a lot about 5 years ago, in a large review of all the statins, there was no association with increased risk of memory problems. We do know it's important if you've had a stroke to be on a statin to reduce your risk of further strokes. But there's some data to suggest that the statins that are more likely to pass into the blood-brain barrier to get to the brain may be more detrimental or more associated with some memory problems than those that are not. So I would say if you do need to be on a statin, talk to your doctor about the type of statin, potentially, because there may be some healthy fats in the brain that could be beneficial, and we don't want to reduce those too much. So there's a little controversy there about that. But if you need it, talk to your doctor.
Right. Oh, that's so good to know. All right, this is an important question. Despite good sleeping habits, I still only average about 5 hours a night. Is it better to take sleep medications and sleep more? Or does napping help during the day? Or what can I do to sleep better?
Yeah, so I think this is a very important question. I mean, a lot of us who have problems sleeping can't just say, just sleep, I'll just lie in bed and toss and turn. I think it's important to think about what's causing those sleep problems. So if you haven't seen a sleep specialist, it may be worth evaluating or talking to a sleep specialist, because there may be some other diagnoses that we don't know about. Obstructive sleep apnea, where you stop breathing while you're sleeping, maybe, and when you stop breathing, you're not getting oxygen to your brain. So then, of course, your brain isn't going to work well, and that causes that frequent awakening. If there are other causes of sleep difficulty, I think it's worth evaluating. So that would be very helpful, and that's something that I do with all my patients, is screen for a sleep disorder so that we can fix, if that would be sort of a low-hanging fruit for someone who has maybe insomnia. And of course, the next day, we're all just tired, not thinking clearly. So that's important to do. And then other things like, exercise, right? So I know this person's saying, I'm already doing all the right things, but I would just emphasize, if you're exercising, a lot of times you're more likely to be tired at the end of the day, and having that sleep hygiene. It's tough when the time change, right? So that makes this hard for all of us. So the routine, I think short naps might be good too, 20 minutes, but not longer, so that you don't ruin your sleep cycle.
Yeah. Do medications for sleep impact the brain?
Oh, yeah, thank you I just talk too much, and then
Oh, no,
part
I'm
of it.
tracking. We're all tracking, right?
So there's certain medications I'd really sort of counsel away from. And so those are the antihistamine type of medications, like the Benadryl or diphenhydramine or things like that, because even though that can make you sleepy, it actually can worsen cognitive function, in particular with older adults and young kids. So I would caution away from that. There's certain types of sleep medications in the class of benzodiazepines that can cause this sort of tolerance effect. So the way that we might say, oh, I'll try a shot of whiskey to go to bed, and that might calm you down. It causes frequent awakenings, and then you need more and more to have the same effect. So I would counsel away from benzodiazepines. Things like melatonin that our brain naturally makes, if that works for you, then I would say okay. But I think truly trying to figure out what the underlying cause is more important.
Right. You know, sleep apnea is so underdiagnosed in women. You know, we tend not to snore quite so much with sleep apnea. We tend to just be more really tired during the day. So if you're just fatigued and you felt like you slept okay last night, that might be something to think about. You know, I always think of a Venn diagram, sort of the overlapping circles. There's mood, there's sleep, there's cognition, right? And all of those things really factor in together. And so, you know, prioritizing sleep, you know, one of the things I talked about last year was I'd only been here a few months, and, you know, my patients in Portland were more kind of anxious and depressed, but everybody here is just not sleeping. Nobody's sleeping in the Bay Area. All my patients in Portland were more mood disorders. You people just don't sleep. And so I don't know.
But I think that's a good point, because like because we look for sleep disorder problems, but sometimes there's anxiety. So maybe I'm worried about some big talk I'm going to give the next day, and I keep waking up, you know. So anxiety can also contribute to sleep problems. So trying to get at the underlying issue and then treating it appropriately rather than just covering it up with a sleep medication.
Exactly. And so, you know, we have a sleep expert. We have a huge sleep center at Stanford, which is wonderful. But one of the things I've learned from them is that often the tiredness and the, you know, feeling like you're so tired but you just can't sleep is about what they call hyperarousal. And it's that sort of anxiety, that list making, all those things, you know, that you know, it's not that you have a headache or your back hurts, it's that your brain won't turn off. And so there are ways to kind of work with that, to try to calm that sort of active brain so that you can go back to sleep, even just simple things as breathing or doing a little bit of gentle yoga before you go to bed at night. You don't want to do vigorous exercise right before you go to bed. Would you agree?
I agree
with that?
for sure.
Right.
Yeah.
But some sort of gentle stretching or calming exercise can be very helpful to promote sleep. All right, here's the million-dollar question. Everyone wants to know, are there supplements or vitamins that I should incorporate into my diet? I hear about creatine, about turmeric, fish oil, B12, collagen, L-theanine, vitamin D. This person knows all of them.
Let's go through every single one. Yeah.
What should I take? What should I take for my brain?
Let's go to the pharmacy right now. No, and I tried to allude to this, you know, even though there may be some suggestions. So I kind of talk about these supplements a little bit earlier about, say, coconut oil or, you know, curcumin and things like that. There isn't enough strong data for me to say, you must take this. You know, my mom said, oh, I watched that TV show and they said I got to eat blueberries, you know.
Right.
But truly the best, and you have blueberries in your meal, by the way. So, but truly it's the balance. And so as much as there may be supplements that may be trying to improve upon some deficiency, truly to have a balanced diet is what's key. And that's why that Mediterranean heart-healthy diet has been the most studied. But I would say that if you're trying to get a supplement, that would be only if you're deficient in something. So oftentimes when someone comes to me to the clinic, we make sure that there hasn't been a vitamin B12 deficiency, because that can cause neurologic damage. We often check for thyroid function, because that can cause neurologic damage. But we don't often check for some of those other things because there's not a clear association. And there's some supplements that if you get too much, that can cause neurologic damage too. So I'd caution you carefully about taking too many supplements, but having that balanced diet is so much more important. Again, You don't have to stop eating rice like my dad, but you just have to have that balance of fruits, vegetables, lean proteins. And I try to do that as much as possible.
Right.
With that cookie every once in a while.
Right. Exactly. You know, I think we get so wrapped up in trying to be perfect that we just throw up our hands and say, well, you know, I'll never be vegan, so I might as well have that burger and fries anyhow, you know, and it's not an either or. And, you know, if you need your burger and fries, have it, enjoy it, that's fine, whatever. But then the next day, have it be your rice and bean day with your salad, and really try to be vegan light if you can, now and then. You know, a whole food plant-based diet is so beneficial for our heart and our brain, and so
I tell my family I'm plant forward now. So, but with pescatarianism every other day. So I'm trying, you know, it's getting there.
Right. I mean, that's perfect, right? I mean, nobody's perfect. I grew up in Texas. We didn't think we were eating a real meal if the steak wasn't hanging off the plate, you know, and so, you know, the changes that you make are incremental. And even, same thing with exercise. If you stand up from your desk for 30 seconds or a minute, or you walk up one flight of stairs, you get benefit. If you have one vegan meal, you have benefit. So don't let perfect trip you up. Just do the best you can. You know, if you're lucky, you wake up tomorrow and you have another day to come at it again. So, you know, just knowing these kind of things help you to make those little baby steps that can turn into really big changes. So don't let perfect trip you up. But I have to say, I agree with you about the supplement question. I get this question all the time. And, you know, good health doesn't come in a bottle. It just doesn't. It comes, you know, it comes from walking around and being in nature. You know, I read somewhere that being in nature quiets the ruminating part of the brain. And so don't the Japanese call it forest bathing or something like that, where you just are bathing in the beauty of nature?
Yeah, some research I had seen was that we're looking towards the horizon more when we're in nature, you know, looking up as opposed to sort of too much of that rumination and that anxiety. So, and again, we don't fully know what it is, and I saw somewhere, not in scientific literature, but saw somewhere about how maybe there are things with certain trees that are secreted that kind of calm us too. So I don't think we can bottle it. If we did, we'd all be doing that. So we'd have to actually do the work.
Right, exactly. But incremental steps is perfect. You don't have to be 100% all the time. Here's an interesting question. What is the impact of learning something new after age 65, like taking up a language or playing the piano or doing crossword puzzles? Do any of those things help stave off decline?
I would say yes, but I don't want you to go do crossword puzzles if you hate them like me. I'm terrible at them. Don't go do that, you know.
Oh, good.
'Cause someone will say, oh, well, you know, I need to tell my mom she needs to go learn this language, or I'm making her do these puzzles. Do what you enjoy, you know. So if you like being here, come back next year. Talk to us, you know. Something that you feel like is stimulating to your brain. And I always find that for people who are doing something they enjoy, they're more likely to do it again. Something that's interactive is also very helpful. So if people say, oh, I like to read, but if you're part of a book club, isn't that more fun? You know, you talk to people about what you learn, you're getting different opinion. What the research is showing actually is that if you combine the cognitive stimulation, the socializing, and the exercise all in one. So who plays pickleball, right? It's like right? There are a lot of, but you're getting together with people, you're learning something new, you know, and you're exercising. So you don't have to do all that. But our research studies, not on pickleball, but on tango and things like that, where you're learning something new. But you don't have to learn something new. So say it's an old hobby that you gave up, you know, photography, pottery, whatever. I have my own plan for when I stop working, you know, and I think figuring out what you enjoy is the most important. Just like you said, don't have to be perfect.
Right.
It doesn't have to be new. It could be something old, but making your brain think is really the key.
I have to say, you are not allowed to retire. We need you. So we want you, that little 99-year-old researcher, you know, still working on it. So, but if you do, okay, you know. But I think you're right. I say that to my patients too. Don't run if you hate running. Why would you do that? You know, I mean, you don't want to just be hating every minute of what it is you're doing. Find something you love. If you love running, more power to you. I don't know. Are you a runner?
I used to be until my knees bothered me, yeah.
Yeah, I don't like to run at all, but I love yoga. So, you know, do what you love. You want to do a mixture, though, of cardiac and strength training. You know, you don't want to do one or the other. You want to do both. Are there studies that I can participate in if I'm experiencing the early stages of dementia? What kind of studies do you have going on that people can?
Everything, yeah.
Oh, really?
Well, you know, I think, well, one, I love this question, and thank you for asking it, whoever you are. You know, we need to learn more. You've heard me say that, you know, there's some limitations to the knowledge and the data that I presented, and some of it has to do with more participation. More women, you know, need to participate. People of different backgrounds need to participate. So I love that question. There are different types of research that we have going on. One is an observational research, which means that we see how you are, check up on you once a year, you know, get some PET scans, get an MRI, do some memory testing. Have you donate any bodily fluid you're willing to donate, and we'll analyze it and bottle it, freeze it, all that stuff, and we're trying to learn what makes you you and how you're resilient or some difficulties you have, how that compares to other people who are going through the same thing or how that's different from other people. We also have clinical trials. So for us to develop new drugs so that we can find the next cure or prevent, we have lots of different clinical trials, whether it's Alzheimer's disease and at different stages, whether it's the Lewy body dementias and all types of things. And it's so important to participate. So I really appreciate that. So
how do people reach out to find out, to get into those?
We have our website that I can share with you. We have a couple tables from our researchers represented outside when you leave today, so feel free to reach out to them. Our Alzheimer's Disease Research Centers are a huge research program funded by the NIH. Hopefully will continue to be funded. And that's our observational program where we recruit people who are normal aging, people who have mild cognitive impairment related to Lewy body dementia, Parkinson's disease, and Alzheimer's disease. And we have a couple of clinical trials that we're recruiting for Alzheimer's disease in the mild stages as well. We have ongoing prevention clinical trials, but we're not recruiting anymore for that. But we're always looking for more and the next new thing. And that's part of my passion. So sorry, I could keep going on forever about that.
Do you see patients and do research? Do you?
Yes. Yes.
Do you sleep?
I hate to admit that when my kids were young, because I really you can tell that the exercise is the number one for me. I would do it late at night, and I don't recommend that because that would be when they would go to sleep, and I'd say, okay, I'm going to sacrifice my sleep to exercise. And then as time went by, you know, I started putting the exercise on my calendar so I could have it at a decent hour and plan for it and make it part of my routine. And that's how I build it in, but thank you.
Right. Oh my gosh, that's such a powerful technique. It's just something you really want to do. Put it on your calendar. We schedule everything else, right?
And little reminders, you know, don't tell IT, but my password is exercise more. And it's through the years, it's like,
I can't
exercise
believe
1,
you said
exercise
that.
10, exercise, like, don't tell them. Are we being recorded?
We might need to edit that out. Oh my God. But that's actually really, I love that. I love that. That's so great. Okay. So I have to ask, what about apps? You know, are there any apps that you like for brain training?
Yeah, I will say that I haven't looked at anything specific, but there were some apps and sort of computer programs that got some notoriety in the day, and one of them actually had to pay out some false claims. Oftentimes what happens is with certain apps, they might train you to be better on that app. Does it apply to real world? Right. So I think if there is an app that you enjoy, great. But if you'd rather, again, do something different,
right,
then do that.
Do something you like.
Yeah.
Yeah. So final question, what one tip have you learned through your work that you swear by?
Yeah, wonderful question. I had an answer because she gave me a prompt, and it was going to be the exercise. But But in this discussion and sort of the reflection on life, tomorrow's my 49th birthday, so I do a lot of introspection. Thank you. Aw, very sweet. You know, as much, so I would say 5 years ago, I said, it's exercising, you know, and I do agree, but I think it's sort of giving yourself the grace to do everything that you know you're trying to do. So whether it's eating healthy, the exercise, spending time with people, sleeping well, all of that. I try to follow everything that I've said here. I get on a soapbox enough, so I said, I gotta follow what I say. But there's certain days it just doesn't work out. You know, I will eat that cookie, or I will have that day that I didn't get a chance to do that X, Y, and Z. And so giving yourself that grace, because that stress isn't worth it, right? To feel at peace with who we are and appreciate who we are. So, what about you? What about yours?
What you said. I don't want to even follow that because it's so perfect. It's such a perfect way to end this. I really appreciate you sharing that because I think we're so hard on ourselves. And, you know, sometimes I'll find myself saying things to myself that I would never say to a friend. You know, I'm just harder on myself than I need to be, and I think we all do that. So I'm just going to leave what you said and say, absolutely. I think that is the Sermon on the Mount. That is the words of wisdom. So thank you so very much for being with us, Sharon. We are so lucky to have you, so lucky, and I really do want to talk to you because there's so much we could do together.
I know.
So
we met part of this, and
I know.
Gosh, we have so much we want to talk about.
Let's just cook up some fun. Let's do some things. And thank you, all of you, for your thoughtful questions, for being here today. I really hope, we all hope, that this was helpful for you and for your loved ones and the people who love you as well. Couple things, QR code that will take you to a landing page for ways you can support the programs that we've talked about today, as well as some health resources that are available to you. Along those lines, we really hope to see you at Health Matters on May 17th. It is the most fun thing. It's like a farmer's market, except for health, and there's farmer's market for health there too. But it's all about healthy booths and experiences and things you can walk around. I'll be there talking about all things menopause. We'll have menopause trivia. We'll have menopause swag. It'll be very fun. So that's May 17th. Please join us. And then there's a to-go coffee cart in the lobby. And there are a couple tables out there with some experts. And if you want to talk and chat, please swing by and join us there. And then please join us next year. This is really a fun event, and it happens every year. So until then, thank you, be well, take good care.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.